like to get this video in a PDF form, please look at my links below. So let's get started. The respiratory assessment consists of subjective data and objective data. Subjective data is what the patient tells you. I'm short of breath, I feel this, etc. Objective data is what you observe from the patient. Objective data involves 4 main steps: inspection, palpations, percussions, and auscultation. Inspection is when you use your vision to observe the patient's behavior, appearance, and movement. So you're just looking at them and looking how they appear. Are they diaphoretic, etc.?
Okay, my friend, that question sometimes NCLEX would ask. Keep it very carefully. NCLEX board, which is the health assessment, right? I said there's so many videos, but the few questions we will be get from in the board, what I'm sharing in during these videos, and trust me, it is super enough. So if the question come from health assessment in respiratory system, they can ask, what are the consequences of respiratory assessment? Like, first of all, you have to inspect, right? You have to inspect. Inspect means you have to observe or watch the patient chest, anterior view and posterior view. Question come, what you have to see, what you have observed. You have to see the patient chest structure, the symmetry, both sides, any kind of abnormalities, visible engorgement vein, any mass, any abnormal hemorrhagic spot like ecchymosis or bleeding spot. You have to see any visible artery, vein, pulsation of the artery in the neck area, right? So also you have to see any kind of abnormalities of the structure of the chest. Sometimes the curvature of the spine is not normal. Sometimes, if like barrel-shaped chest, lordosis or scoliosis, abnormalities of the chest. If you see anything abnormal, you have to document. After the inspection, you have to check palpation. Palpation means you to touch the patient chest, and then you can feel. If patient have any kind of pain, they can express by facial expression. So first of all, you have to go for superficial palpation. Then you have do the deep palpation. Deep palpation, I said. So touch the body to feel any kind of tumor or mass. If you have it any, if you see any, then measurement the size, shape, border, right? And also when you palpate, check any kind of tenderness or shape. After that, we have to go for percussion. Percussion means tapping against the body surface to produce the sound. So the lungs, basically the organ, the full of oxygen. You know the guitar. Guitar is the air inside. So if you tapping over the guitar, it make a sound. But if you tapping over the solid organ like liver, we will get a dull sound. But if you percuss or tapping over the lungs area, we can get a sound because the lungs is full of air. If we do not get sound, if the sound is dull, means the lungs is full of the any kind of pathology like consolidation. Auscultation, finally, we do just put the stethoscope, the earpiece in your ear, definitely, and diaphragm over the chest, and you has to check any kind normal first, then any kind of abnormal lung sound. As I told you, the three sound is normal. Over the trachea, if you put the stethoscope, we has to get the bronchial breath sound. Bronchial breath sound over the trachea is normal. Okay. Same after that, we has to put the stethoscope in the central area of the lungs, and we has to get vesicular lung sound. Vesicular lung sound, right? So as I told you, the bronchial sound is louder on expiration, okay? And you get it over the trachea. And another one, vesicular, we can get it over the central part of the lungs, left or right, both. And it is louder on inspiration, louder, I said. Another one we can get is called bronchovesicular. Bronchovesicular. So one is the over bronchial, other is called bronchovesicular, and last one is called vesicular. Vesicular sound we can get in the peripheral lungs. I want to recap it, my friend. That normal lung sound are three: bronchial, bronchovesicular, and vesicular. Bronchial lung sound we can get over the trachea. Then bronchovesicular sound we can get in the central part of lungs. Third one is called vesicular sound we can get the periphery of the lungs, right? When you put the stethoscope over the lungs, we also check any kind of abnormal lung sound. Abnormal lung sound means any kind of wheezing or stridor or crackles or friction rub, right? So the wheezing is most commonly asking question in NCLEX board, but it's abnormal. I want to recap it for you. Abnormal lung sound are wheezing, stridor, crackles, and friction rub. So wheezing usually we can get during expiration, but crackles usually we can get during inspiration. Stridor, sometimes we can get inspiration and expiration both, but friction rub we have to get either inspiration or expiration. So most commonly asking question is called abnormal lung sound is wheezing. Wheezing, sometimes we can get over the bronchi or trachea during bronchial asthma, because during the bronchial asthma, the airway is getting narrower because of constriction, narrow, and wheezing is produced. And I'd say the crackles, another sound, but we can get in the peripheral lungs because of occluded the airway. And stridor, we should got in larynx or pharynx, the upper respiratory system, upper part, larynx or pharynx, we can get the stridor. Laryngeal stridor will get during laryngeal stenosis, and stridor we can get over the pharynx when partial obstruction over the upper respiratory tract. The final abnormal lung sound are called the friction rub. Friction rub, as I told you, it is sometimes get inspiration or expiration over the chest wall we can get. And friction rub most common in case of any kind of inflammatory disease, inflammatory or inflamed pleura. What is pleura? Pleura is the outer layer of lungs, right? So as I told you, step by step or consequence of respiratory system examination, we have to follow inspection first, then palpation, then percussion, finally auscultation. I want to recap. Inspection means you have to observe, you have to see. Palpate means you have to palpate over your palm of the hand. Percussion, you trapping. And auscultation, you have to use the stethoscope or Littmann using the diaphragm and listen the normal heart sound and abnormal heart sound.
Palpation is when you use your hands and fingers to touch their body to feel. You're going to feel the size of the organs, the tenderness, the shape. Percussion is when you use your hands and you tap against their body surface to produce a sound. Auscultation is when you listen with a stethoscope to breath sounds. So the first one, like we said, was inspection. What you're going to be looking over here is at the patient's color. Are they pale? Are they yellow? You're also going to be looking at their appearance. Are they sweating? Are they trying to catch their breath? You're going to be looking at the chest wall movement. Is it rising and falling like it should? Is it equal, symmetrical? You're also going to be looking if they're using their accessory muscles, which is abnormal. Another sign of the respiratory is their nails, clubbing of the nails. That means that they have long-term oxygen depletion. And last but not least, you're going to be checking the respiratory pattern. Here are the following respiratory patterns that you should know. Eupnea is normal respiratory pattern, which is 12 to 20 breaths per minute. It's how one should be breathing. Apnea is absence of breath sounds. Bradypnea is the same thing as normal, so you're going to see chest rise and fall, but it's just slower, so it's going to be.
You see, during the inspection, what you have to see? The color, patient color over the chest area, anterior view and posterior view. Also, appearance means any kind of abnormalities. Chest wall movement with inspiration and expiration. Also, we have to check the symmetrical movement, right and left, symmetrical. Chest expansion during inspiration and expiration. Also see the accessories muscle, the major muscle of respiratory system is a diaphragm. But if patient has any kind of respiratory problem like COPD, right, constructive obstructive pulmonary disease, that times patient use the accessories muscle, means muscle in the neck, sternocleidomastoid muscle, intercostal muscle are used too much, and you can see there's something wrong. Also, we have to check for any kind of hypoxia, like clubbing, right? Clubbing is the bluish ring on the tip of the nail bed, yellow lobule, tips, or lips. And also, we have to check the respiratory pattern, means is the respiration is abdominal or thoracoabdominal or thoracic pattern. So now we are talking the respiratory pattern. The normal respiration or normal rate of respiration is the 12 to 20 beat per minute. And normal respiration is called apnea. If the respiration is absent, sedation, stoppage the respiration is called apnea. F stands for absent. Absence the respiration, stoppage. If the respiration is less than 12, is called bradypnea, not bradycardia. Bradycardia is the heart rate. Tachypnea, when the respiratory rate is more than 20, is called tachypnea. What is tachycardia? Heart rate, right? Tachypnea is the respiratory rate. Tachycardia is the heart rate. If your patient has a diabetic mellitus and diabetic is not under control, we can get a special type of fruity order respiration. It's called Kussmaul respiration. Kussmaul respiration is a rapid and deep respiration. NCLEX board asks, in case of diabetic mellitus, what are the common respiratory pattern? It's called Kussmaul. Even sometimes asks in NCLEX board, what are the nature of Kussmaul respiration? This is a rapid respiration, deep, lobed. Also, in other respiration, we use called chime stroke respiration in kinds of chest disease is rapid and deep, but most commonly asked question, Kussmaul respiration in case of diabetic patient, and nature of Kussmaul, this is rapid and deep.
Be below 12 breaths per minute.
What does it take to be the nation's #1 cancer center? It takes subspecialists.
This could be found like when someone's sleeping, when someone overdoses, like that. Tachypnea is also normal, so the chest rises and falls, regular breath, but it's much faster, so it's more than 20 breaths per minute. And this could be from a fever, from compensating mechanism. Then we go on to Kussmaul respirations. So this is rapid, deep, and labor. They're usually found in DKA patients, metabolic acidosis, or even renal failure. And the last one is chain Stokes. So this is a rapid and deep, and then you have a period of apnea. Chain Stokes is usually found with head injuries, strokes, overdoses. Palpation. A normal palpation should not cause pain. If it does, you should assess what's happening in that area and why they have pain. You want to palpate for tenderness, bulging, and stuff like that. You want to assess for crepitus, which is, you're going to hear, which is abnormal, and it signifies subcutaneous ear in the chest. This is going to sound like a grating, cracking sound. You also want to do tactile framintus. It's when you place both your palms on a patient's back and you ask the patient to say 99. They're going to say 99, 99. You're going to note the areas of asymmetry, or if they're decrease or increase in one area. As you see in the left picture, that's the correct placement of your hand. Another thing you want to do is you want to evaluate for chest expansion. So as you see in the right picture on the bottom, you're going to put your thumbs at the 10th rib. You're going to tell the patient to inhale, and your thumb should move apart symmetrically. The same thing, exhale, and they both should move symmetrically. They shouldn't have pain in the area. You want to check if one is not moving symmetrically. It could indicate atelectasis, pneumothorax, or a pneumothorax. So next we go on to percussion. So percussion is when you're going to place your non-dominant hand, hyperextend that middle finger, and then take your dominant middle finger and you're going to tap it on your non-dominant middle finger. As you see in the picture below, that's exactly what the provider is doing. Taking the dominant middle finger and tapping it on the non-dominant middle finger, which is on the patient. It's going to be a quick and sharp one, so it's going to be a quick and sharp tap, and you want to go from side to side comparing. You're looking for sound variations. Normal sound is resonance, which is going to sound hollow, and it's going to be heard over normal lung tissue. Flat is going to sound like soft and high pitch, and it's going to be heard over consolidation, so like atelectasis. Dull sound is going to be like medium, so medium pitch, medium everything, and it's heard over a solid area, so it could mean pleural effusion. Hyperresonance is loud but low pitched, and it's heard over hyperinflated lungs, like emphysema. And the last sound you could hear is tympanic, which is a musical drum-like sound, and it's telling you that there's ear collection, so there could be like an ear bubble. Next we go on to auscultation. Auscultation is when you're listening to the breath sounds using a stethoscope. You want to listen for inspiration and expiration. You want the patient to be sitting up upright and tell them to breathe deeply through their mouth. Normal breath sounds. There are 4 types. Number 1 is tracheal. Tracheal sounds harsh and discontinuous. It's heard midline over the trachea.
JBU Online has some exciting news. You can now earn a 4-year bachelor's degree from John Brown University.
The next type of normal breath sound is bronchial. It's heard over the trachea, like the large airway part. It's loud, high-pitched, and it's especially heard during exhale.
You see this picture, normal breath sound. So if you put the stethoscope over the trachea, we can get the normal, it's called bronchial. If you put the stethoscope in the central area, around this bifurcation area, we can get the bronchovesicular. And if you put the stethoscope on the periphery, we can get the vesicular. So before my exam, before my RN license exam, before my MD license exam, what are the easy way? I remember, just follow me, my friend. That area is close to the midline. Then this little bit far, and the periphery is more distance. In alphabet, B is close, the small b is close.
Exhalation.
Victor B. So I remember the boy B bronchial is close to the center. In between combination of these two, broncho vesicular, and in the most distance, according to the alphabet, this letter is little bit distant than this small b. So vesicular by sound, we can get the periphery. So I remember the small b or boy b is close to my midline. In between these bronchobesiculars, one small b come here and vesicular b came over here, they meet in between. And vesicular in the periphery. This type of clue helped me to get a confident during the exam time, right? Because you need the license rather than anything else. So when you feel comfortable to hook up, you should do. If you're wrong this type of question, you miss this point. The stridor, the sound. Stridor is the abnormal, but stridor we can get over the pharynx or larynx. Usually, if any kind of obstruction in the upper respiratory tract, like pharynx or larynx, we supposed to get the stridor.
Then goes bronchovesicular, which is medium and continuous sound. It's heard over the scapula on each side of the sternum. And the last one is vesicular, which is what you're going to hear over the rest of your lungs, which is soft and low pitch. As you see in the diagram below, it's showing you where you could hear all of them. So now that we discussed the normal breath sounds, we're going to go on to the abnormal breath sounds. The first one we're going to discuss is crackles. Crackles is the same thing as rails. These are discontinuous crackling, as the name sounds, clicking like crackling, clicking sound. It's heard during inspiration. They could be fine or coarse crackles. This indicates the alveoli is collapsed or filled with fluid. The next abnormal breath sound is stridor. So stridor is high-pitched sound that's heard during inspiration. It indicates an upper airway obstruction. The next one is wheezing. So wheezing is also high-pitched, but it's like a whistling musical sound. It's heard during inspiration, and it indicates a lower airway obstruction. The next one is pleural friction rub. This is hard, grating, cracking sound that is caused when two layers of pleura rub against each other. So they could be inflamed, which causes them to rub against each other. Okay, so here's just a diagram that shows you where you should auscultate, so where you should place your stethoscope to listen to breath sounds. And as always, remember, you're going from one side to another to compare both sides. So thank you for watching. If you want to...
So basically for NCLEX board, they ask you if they ask you the abnormal heart sound like crackles, wheezing, or stridor, or plural rub, they can ask what medical condition we supposed to get abnormal heart sound. As we discuss, the crackles we supposed to get in case of any kind of atelectasis or pneumonia, right? Pneumonia means infection of the lungs, and then fluid accumulate inside the lung if it is untreated, pneumonia. Or crackles we can get in fibrotic lungs disease or pulmonary edema. So when water or fluid accumulate in the lungs is called pulmonary edema. So pneumonia, pulmonary edema, we can get the crackles, wheezing, most common one. It is common in case of bronchial asthma or pulmonary edema or bronchitis or chronic heart failure or bronchiectasis, or we can get it if any kind of tumor inside the lungs. Another abnormal heart sound is called the stridor. Stridor we're supposed to get if the upper airway extrathoracic obstruction, upper airway obstruction, we can get the stridor. Partial obstruction of the larynx or pharynx or trachea is stridor. And last one is called pleuritic rub, like pleural rub. Pleural rub basically we get in case of inflammation of the pleura, inflammation like pneumonia, pulmonary infection, right? So this is the basic about the lung assessment.